Please go ahead.
A very warm welcome to one and all to this very important webinar. Thank you all for logging in from different parts of the country. We hope you're keeping good, and we hopefully looking forward that you have a good educational meeting for this afternoon. So I, Dr. Rins Paulos, working as a senior medical advisor at Novo Nordisk, also would like to thank the organizers, Mumbai Hematology Group, for driving such an important and very apt topic pertaining to hemophilia. I'm sure this is going to be a lot of interactions, discussions, where we're trying to achieve an improvement in the standard of care. And we hope from all the attendees who have logged in as well, with your all doubts, comments, or even clarifications, you're itself going to be updated with the right learnings for an improved clinical decision-making in your practice. So I think with this very precise and crisp introduction towards what we are trying to see from the different interesting topics that are going to be covered in hemophilia, I think I would like to also hand it over here to Dr. M.B. Agarwal, so who has been a very known faculty to each one of us and beyond the group as well as across the country, and also instrumental in driving such wonderful webinar series. And I think with all these, I will just hand it over, sir, and take over the proceedings from here. And we look forward to a great meeting. Over to you.
Thank you, Dr. Rins Paulos, for that introduction. Good morning to one and all. Today, our guest speaker is Dr. Rosalind Doan from France. We also have Dr. Mukul Agarwal from Delhi. This webinar is brought to you by Mumbai Hematology Group. It is supported by Novo Nordisk and Nirvin, and it is managed by Perfect Square. I thank Dr. Rins Paulos, Mr. Malcolm Fernandez and the team Novo Nordisk, Mr. Paresh Prabhugaonkar and team Nirvin, Mr. Yash, Mr. Kalpesh and the team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest today, Dr. Professor Chandrakala S. Our guest speakers, Dr. Rosalind Doan from France and Dr. Mukul Agarwal from India. All our discussants who are themselves eminent pediatric or adult clinical hematologists or hematopathologists. And you participants for sparing your Sunday morning, afternoon, evening, depending upon which part of the globe you belong to. We have today registrations from almost 27 countries. The website of Mumbai Hematology Group is www.mhgindia.com. MHG for Mumbai Hematology Group. Simple to remember, there is no password. This is a window to all our future academic events, and you can register for whichever is relevant to you. To give you a glimpse of next weekend academic sessions, Saturday, 29th of October, 7 p.m. IST, we have advances in radiotherapy for hemato-oncologists by Dr. Dabaji from MD Anderson, Houston, Texas. And next Sunday morning, 30th of October, 11:30 IST, we have diagnostic workflow for hereditary erythrocytosis and thrombocytosis by Professor Mary Frances Macmillan from UK. We have a galaxy of very important personalities as discussants today, and they've been displayed here alphabetically. I'll just introduce them to you. Dr. Akanksha Garg, Dr. Akshaya Mandloy, Dr. Amrita Saraf, Dr. Ankit Rayani, Dr. Arihant Jain, Dr. Vijita Datta, Dr. Gunjan Prasad, Dr. Jyoti Kotwal, Dr. Kapil Garg, Dr. Kunal Goyal, Dr. Mahadeva Swami BC, Dr. Manoj Toshniwal, Dr. Mukul Agarwal, besides being speaker, is our discussant as well, Dr. Nilesh Vasekar, Dr. Prashanta Bhatt, Dr. Radhika KK, Dr. Rajat Bhattacharya, he's from Singapore, Dr. Rajat Jain, Colonel Dr. S. Venkatesan, Dr. Samir Malinkari, Dr. Shruti Kakkar, Dr. Tejaswini Gudibande, Dr. Varun Bafna. Now it's my pleasure to introduce our chief guest of the day, who will inaugurate our webinar today. And that's none other than Professor Dr. Chandrakala S. She's MD DM. She's Professor and Head Department of Clinical Hematology at the prestigious KEM Hospital, Parel, Mumbai. She did her fellowship in leukemia and bone marrow transplantation from BC Cancer Agency, Vancouver. She's a teacher for DM Clinical Hematology. She's been working in KEM Hospital, Mumbai for the last 14 years from 2008. She has been Medical Associate of International Hemophilia Training Center in Mumbai. She's Treasurer of Indian Association for Hemophilia and Allied Disorders. She did her DM in Clinical Hematology from St. G.S. Medical College in KEM Hospital, Mumbai. And prior to that, she did undergraduate and postgraduate qualifications from Mysore Medical College and KIMS Hubli, respectively. She has authored and co-authored over 25 peer-reviewed articles in national international journals of repute. She has been PI for various clinical trials, including hemophilia, ITP, and MPNs. She has participated as a faculty in innumerable national and international conferences. I request her to inaugurate our today's webinar and give some words of wisdom to our fellows and trainees. So over to you, Professor Chandrakala.
Thank you, sir, for such a kind words. And indeed, I'm very highly privileged and honored to be chief guest for this meeting. And I want to tell actually how my course in hematology and how it's going on now and what is the future in hematology. And to tell how I joined hematology is it goes back to 2002. When I was doing my MD in Hubli, I came to Mumbai to attend a meeting which was conducted by Agarwal sir in 2002 in Mumbai, in Bombay Hospital. And the two talks were actually influenced me to take up hematology as one of my super specialty subject. One was given by Agarwal sir, like thalidomide, like old wine in new bottle was one of the talk. And then the other talk by Maman sir, Maman Chandy sir, like a DI. These two talks were so encouraging that I thought like hematology is a very interesting subject and a lot of new advances are happening. So then I did my DM in KEM Hospital, Mumbai, after my MD, and we came to Mumbai and did that. So to come to hematology, it's the only subject, as far as my knowledge, showing that so much translational research from bench to bedside is happening now, which has shown tremendous improvement in patient prognosis and cure of many patients. And now many of the new drugs, see, initially what used to happen is new drugs used to get launched in the Western world and it used to come very late in Indian country, like in our country. So now many new drugs are launched simultaneously or more or less like similar time in our country also. And we are getting a lot of generic drugs, which makes our patients can get more affordable treatment. So now coming to hematology, it's actually classified as like classical hematology, which used to call as benign hematology and now malignant hematology. So coming to this, classical hematology, when I joined in KEM in 2004 as a resident, DM resident, so for the today's topic, what we are talking is hemophilia. We used to give cryo, plasma. That was cause more than 90% of the patient would be disabled. So now with more and more recent advances like extended of life factors, monoclonal antibodies, we're getting more and more patients. Almost 80 to 90% of the patients bleed free. So such a contrast has happened in actually 1 decade or 1 to 2 decades. We have seen such a progress in the hematology. So even in actually not only in hemophilia, coming to this inherited disorders like thalassemia, sickle cell anemia, we have seen a tremendous progress in the form of monoclonal antibodies, so which also is available to our patients in our country. And like malignant hematology, now with the better prognostic markers, we are able to categorize patients better and better. And in the malignant hematology also, we have got a lot of translational research which has shown into the trials have done, and it has come into the market and which has shown improved survival with a better chemotherapy free. Actually, chemo-free drugs we are giving, lot of targeted therapies we are giving. So all these patients, like even the benign or the classical hematology patients or the malignant hematology patients are with you in the difficult and we are both happy times. So in hematology ward, we see a patient, pediatric patient with a big line, with a broad smile, and the son of an elderly patient with a misery. So this is a spectrum of patients we see, and where we have to deal with very patients. So we need to practice ethically so that all of us can have a peaceful sleep. Majority of our patients come from a very low socioeconomic status. So still we are able to treat many of our leukemia patients and lymphoma patients with philanthropy support, and we have got many new government health schemes. So with this support, none of our patients are sent back just because they cannot afford treatment. So in hematology, we can get so much of support when we can treat almost all the patients with the better care, with the support. So we have to see, just because we have taken hematology and we are in private or the government hospitals, we have to approach for the philanthropy support for our patients so that many of our patients can get cure of this disease. So, and after the malignant hematology, we have got bone marrow transplant, CAR T cell therapy, BITE therapy, which is helping us to cure many of our cancer patients and even classical hematology patients. With advances in conditioning regimens, availability of new drugs for GVHD has shown a tremendous increase in the survival. But one thing we always have to worry is that majority of the patients don't get the transplant. So in our country, we require about 1 lakh transplants per year, but we are doing only 2,500 transplants. So many of the hematology students, many of the residents who want to take up hematology super specialty it's a large scope to join hematology, to treat all the patients of classical and the malignant hematology with the support we're getting from the either the government or from the other schemes. So every day we see a challenging patients. At the end of the day, you will be able to manage and see patient satisfaction is very heartening to see. So you go to the ward and you see the patient that's smiling, and then we have treated a leukemia patient, and after 5-10 years they come back, the children, they come back with their wife. It's such a heartening to see them, that their satisfaction, it gives us new zeal for every day to work. So one thing I would like to mention is, when we are treating hematology patients, we are not only treating the patients, we are treating entire families involved. In almost all the disorders, we are treating the entire family. And it's always, we should interact with them, its interaction and counseling plays a very important role in the patient's management. And again, I feel that empathy is very important when we are treating the patient. The ability to understand another person's means, the patient's thoughts and feelings in a situation from their point of view rather than your own. So you always talk in medical terms. You always talk in difficult words, difficult to patient understand. So multiple times we have to talk to the patient, and the empathy plays a very important role in the management of all of our patients. And then always think of patients and never forget that there is a family to be fed. So we should treat patients ethically. So we cannot advise a patient where we cannot get a cure to go for a transplant, because they have to arrange a lot of financial support for this. And I end by saying that hematology is a challenging and progressing branch where patient satisfaction will make you to work with a new zeal for work every day. So this will encourage many of our residents to take up hematology, so that a lot of new advances can be given to our Indian patients, and many of the patients can get cured. Thank you, sir.
Thank you so much, Professor Chandrakala, for that lovely address and inaugurating our webinar for the day. And now it's my privilege to introduce our guest speaker. The first guest speaker is Dr. Rosalind Duaun from France. Her formal introduction includes, she is Medical Director, Reference Center for Hemophilia, Rare Congenital Bleeding Disorders, APHP, University Paris-Saclay Hospital, Bicêtre, France. She graduated as a medical doctor from UFR, Brosier Hotel Dieu, University Paris 6, and completed her specialty training with master's degree in hematology, immunology, immunopathology, and transfusion medicine from UFR Saint Antoine University Paris 6. Her research interests are principally in the area of hemophilia and rare bleeding disorders in both children and adults, especially regarding issues on molecular mechanisms of hemophilia A, inhibitors, immune tolerance, mild to moderate hemophilia, carriers of hemophilia, women with bleeding disorders, and Glanzmann's thrombosthenia. She is the current elected president of the steering committee of the National France Coag Registry on Bleeding Disorders. She is also a former elected member of the European Association of Hemophilia and Allied Disorders Executive Committee. With the National Federation of Patients, she has developed outreach programs dedicated to women with families with hemophilia and rare bleeding disorders. Today, she is going to address us on women and girls with hemophilia lessons learned. So over to you. I think our guest speaker hasn't yet joined, so we'll wait for a while for her to join. Okay, as our first guest speaker has not yet joined, what we will do is we'll switch gears. It's my privilege to introduce our second speaker and request him to do his presentation. I'll just introduce him. Our second guest speaker is Dr. Mukul Agarwal. He's DM Clinical Hematology from AIMS, PDCC Hemato-Oncology, MD. He's Assistant Professor in Clinical Hematology at the prestigious AIMS, New Delhi. He graduated from Maulana Azad Medical College, New Delhi, and completed his specialty training with master's degrees in pediatrics from VMMC and Safdarjung Hospital. His hematology training started with the hemato-oncology course at SGPGI MS, Lucknow, and then DM in clinical hematology from AIMS, New Delhi. He also did observership from MD Anderson, Houston, Texas. His research interests are principally in coagulation bleeding disorders, myeloproliferative neoplasms, genomics in hematology, both in children and adults. He has intramural and extramural projects related to his areas of interest. He's a member of various prestigious societies, including EHA, BSH, ISTH, ISHTM, IAP, PHO-IAP, and DSH. He is an executive committee member at Delhi Society of Hematology. He has over 50 peer-reviewed publications in various international and national journals. He's an avid reviewer to many of these journals. He's participated as a faculty in innumerable national conferences. He's going to speak to us on surgery in hemophilia, importance of EHL factors. So over to you, Mukul.
Thank you, sir, for the kind words. I'll be starting with my presentation today. The topic for my presentation is surgery in hemophilia, importance of extended half-life products. This is a brief outline of my topic. I'll be discussing about the pre-surgical preparation of the.
Mukul, your slide is not moving. Okay, Mukul got frozen, so we'll wait for a while to him to log in again. Yeah, Mukul, we can see you now.
Oops.
Yeah, we can see you.
So much has changed over the last 50 years. Earlier it was like patient with hemophilia and undergoing surgery used to have a mortality of going up to almost like 30 to 50%. Now we are in a position that patients with hemophilias are undergoing surgeries. There are multidisciplinary guidelines which are there for patients of elective surgeries. Then factor 7A is available for patients of hemophilia undergoing surgery. And lastly, what we expect, thromboprophylaxis for a hemophilia patient undergoing orthopedic surgery. Even guidelines for that have come. What is surgery for hemophilia? So hemophilia-related surgery can be for related complications like joint damage or root tumors, or we should understand that the hemophilia patients are not immune to any surgical disorders. So they can be unrelated disorders like fractures or acute abdominal, so on and so forth, for which surgical indications may be there. There is this European survey which show that only around 10% of hemophilia patients undergo surgery. Major orthopedic procedure, liver biopsy are most frequently performed, and almost double of this number undergo minor procedures. What is required is an experienced surgeon who is used to dealing with bleeding disorders and experienced anesthesiologist with bleeding disorders, a neuroexcellent anesthesia which requires a factor level of more than 50 IU per deciliter, and definitely everything comes in consultation with a hematologist who is dealing, who has already dealt with patients with hemophilia and helped in managing these surgical patients. First and foremost, it is important to understand, is surgery the only choice left for the patient? Are there any non-medical or medical conditions through which the patient can be managed? Are there other options which are available? Are minor procedures which can be done in a patient or not? Or a major surgery is required? Then, especially for patients who have a larger IC bleed or an extensive joint damage, it is important to communicate with the patient with respect to their expectations and goals of the treatment or the procedure. Next, it is important for the complete treating team to determine what does the procedure entail, how much blood loss is expected, how much, what is the duration of rehabilitation, what is the post-operative restrictions for the patients, is there any physiotherapy which will be required, and lastly, what are the patient needs upon discharge to whom? How do we recommend the adequacy for hemostasis? It is described as excellent when the post-operative blood loss is similar to that in a non-hemophilic patient, that is within 10% of that. And no extra factor 8 or bypassing agents are required. No blood transfusions, extra blood transfusions are required. It is considered good when this number is between 10 to 25%. No extra doses of factors are required. Blood components requirements are similar. It is considered fair when it is 25 to 50% of for the non-hemophilic as compared to the non-hemophilic patient. Some doses of the bypassing or factor 8 extra are required, and clear blood component requires are increased. Poor when everything is out of control and patient may require ICU stay or develops an acute hypotension, or more and more amount of blood products and factor products are required. What should we have? That we should have an adequate quantity of CFC, the clotting factor, or the bypassing patient inhibitors. Bypassing agent for patient with inhibitor should be available for the surgery itself, and maintain adequate post-operative cover for healing and rehabilitation. If the CFC is NA, then blood bank support should be there for plasma component, including cryo. Comprehensive and clear clotting factor concentrate dosing schedule should be made with dose and day and dose well written in advance and should be communicated well to the surgical team, so that these can be given to the patient as well as available with the surgical team and the hematology team. And preferably what we do is we plan and schedule the surgery early in the week, preferably early in day for optimal lab and blood bank support if at all required. So this is traditionally the factor dosing which has been suggested for major and minor hemophilia surgeries, major and minor surgeries in patients with hemophilia A and B. We can see that on the day of surgery, almost all the patients require 80 to 100% corrections. Between day 1 to 3, this can be between 60 to 80% of the levels. 4 to 6, 40 to 60%. And after 1 week, around 30 to 50% dose level should be maintained for adequate physiotherapy. For minor procedures, the duration is between 1 to 5 only, and up to 80% in the first day on the day of surgery, and 30 to 80% subsequently is required. Similar numbers are there for hemophilia B as well. Just remember, for the short acting factors, hemophilia A patient require twice a day dosing, and hemophilia B patient require once a day dosing. What is additionally required is reliable monitoring for clotting factors. We should check for plaque recovery prior to surgery. We do this usually on day -1 of the surgery, or at least on the day of surgery. This should be well documented. NADR levels are checked post-op, and pre-pregnant schedule should be there for checking the factor level post-surgery as well. One should avoid levels above 150 IU per ml, as these have been associated with increased risk of thrombosis. Then again, inhibitor testing is a must. This should be done prior to surgery, and especially in patients who have suboptimal response to treatment in the post-operative period. Transient inhibitors have been shown to develop in patients who undergo major surgery, especially if the patients were earlier not exposed to the factors. This is because of the inflammatory milieu which can occur in the perioperative period. And again, inhibitor testing should be done in a pre-planned schedule, say every 3 to 4 days post-surgery, to look for these inhibitor development after surgery. To say that surgery in hemophilia have been feasible, this is a meta-analysis from various studies, over 1,200 knee replacements in 917 patients, both hemophilia A and B, some patients with inhibitors as well. What they go on to show that there is improved range of movement across these studies, with improvement ranging from effect size ranging from 10 to almost like 50 to 60% in some of the studies. But no, they are not devoid of complications. So hematoma formation is a common complication occurring in around 8% of the patients. There are other complications which can occur, like some patient may require evacuation, infection, deep infections. All these things have been reported, but overall, just the studies go on to share that this hemophilia surgeries are feasible without any extended or advanced risk of other complications. Something which has come up over last around 8-9 years, extended half-life products. How do we define them? These are products that meet the 3 criteria, that is lacking bioequivalence with a standard comparator, demonstrate a difference for the majority of the patients. And they should be made using a technology designed to extend the circulating biological half-life. We'll discuss in the next slide how it is done. And having a half-life of at least 1.3 or higher based on the modeling method. So these are the various methods by which half-life of the product is extended. Commonly used is pegylation method and fusion protein method. Pegylation is with polyethylene glycol. It increases the hydrodynamic volume of the product and prevent clearance by the kidney or by the liver. So the product stays for a longer time in the circulation. Otherwise, the factors can be fused either with the Fc fragment of the immunoglobulins or albumin. And these are recycled through the FcRn ligands at the endothelial cell surface to increase the circulatory half-life of the protein in the circulation. What are the benefits of the EHL? We have seen in the, at least in the prophylactic study, that benefits of the lower frequency will be seen, that the patient will require, especially for factor 8, patient require prophylaxis almost like every 4 to 5 days. And for hemophilia B, patient require prophylaxis every 1 to 2 weeks. So patients will have fewer clinical visits or home care nurse visits, lesser needs for central venous access devices, less burdensome infusion schedules, and increased uptake of prophylaxis. And with the higher trough level, which are maintained with the current dosing schedule of around 50 IU per dose, we result with a more effective prophylaxis schedule and higher level of prevention of bleeding, and probably greater level of sport participation otherwise. Let's come to the topic, surgeries in hemophilia A. So this paper I'll be discussing about a few important aspects. So various surgical procedures have been done. The product have been plasma derived and recombinant. The mode of infusion is continuous or bolus. And the complications of bleeding and hemoglobin drop have been seen in some of the patients. But it goes on to show that patients with blood group O, they tend to have a higher risk of bleeding as compared to patients with non-O blood group. and second surgical intervention is also slightly higher required in patient with blood group O. Probably this is related to the binding with the VWF, which is lower in the patient with blood group O. Then there are some predictors for underdosing and overdosing of factors. So we see that on the initial day, underdosing and overdosing are less frequent, but as the time passes on the post-operative care, after day 5, overdosing is very, very common in the patients. What are the possible risk factors? For underdosing, it's like age, blood group O, and major surgical procedures. For overdosing, commonly it's like blood group O again and product type or mode of infusion, with bolus infusion giving higher doses in most of the patients. Let's come back to EHLs. So this is the Pathfinder study, a multi-level, multinational phase 3 open-level non-randomized study. In this, patients from the Pathfinder 2 studies were taken. They were aimed to give factor activity of 80 to 100% on day 0. Day 1 to 6, factor activity level was aimed at more than 50%, which was continued for up to 2 weeks, after which the patient were put on back on the prophylactic schedule. Overall, 49 major surgeries were undertaken under the study. What we had that there were around 44 orthopedic surgery and 5 non-orthopedic surgery. And the bleed control, as I emphasized earlier, it was excellent in over 50% and good in around 45% of the patient. So overall, around 95 to 96% of the patient had excellent to good overall hemostatic control during the surgery. That is, didn't require any extra factor dosing requirement, and the blood component requirement was similar to that of a non-hemophilic patient. Again, minor surgeries were done in around 45 children, 45 minor surgery in 23 children, and these are on regular prophylaxis. No safety concerns were observed. So what we have surgery from the Pathfinder study is that 96% successful surgeries, major, and 100% effective bleed control in minor surgery without any complication. This is about another factor, 8 extended half-life product. So 26 surgeries, many of them orthopedic and some non-orthopedic surgeries. A similar kind of a dosing schedule was there, and patients were asked to maintain a factor rate level more than 80% for the first 4 days and subsequently more than 50%. Overall results, we see that the overall hemostatic efficacy was seen across the interoperative, postoperative, and perioperative period and was rated as good to excellent. Blood losses were comparable. No other blood transfusion requirement occurred in the interoperative period. There were certain side effects, 5 injury-related postoperative bleeding, which required additional factor support, no deaths or treatment-related adverse events, no serious adverse events of seen. 2 only transaminitis and headache were seen in 2 of the patients. And importantly, none of the patient developed factor 8 or pegylation or the overall factor inhibitory antibodies. So this was considered to be pretty safe as well as non-immunogenic in these patients. Let's come to hemophilia B. 118 patient, 255 surgery, 120 major surgeries, both recombinant and plasma-derived factors. What we had was that bleeding episodes were seen in some of the patients, no thrombosis, some of the patients required blood transfusions as well. Overall, again, we see that for bolus infusion, lower factor 9 levels were the risk factor. With bolus infusion, lower factor 9 levels were the risk factor, and similarly, minor surgical when the bolus was a risk factor for lower infusion. For higher infusions, continuous infusions and bleeding complications were risk factors. And these are associated with excessively higher factor 9 levels in the postoperative period. EHLs. So as compared to factor 8, factor 9 EHLs have a very great advantage in having a big half-life. So half-life of factor 9 inhibitors is around 5 to 6 times of that of standard SSL products. So this is a paradigm study, factor 9 GP, in which the preoperative patients were taking the prophylaxis. On the day of surgery, a single dose of 80 IU per kg was given, and postoperatively levels were maintained above 40. So levels were maintained as per the standard, and 40 IU per kg dose was repeated as per the investigator discretion. 13 surgeries were done. Knee replacement, some other orthopedic surgery, all were done. What we see that hemostatic control was good or excellent in all these surgeries, and none of the patients had moderate or poor surgical outcomes. So most of the patients required only one dose, and the level of the factor was sustained for longish period of time. So what we had at that on the day of the surgery, none of the patients required additional dosing. After the surgery, for the orthopedic patients, some required one more dosing, that is 40 IU per kg between day in the first week. And in the second week, few patients require one more additional doses. So overall, if we see that the median dose was around 5 for the orthopedic surgery and 3 for the non-orthopedic surgery. And similarly, as compared to the SHL products, which require almost like 17 to 18 infusions, and the total dose is tremendously high. So what we are left with is that AHL products, only a median of 2 injections are given in the first 6 post-operative days, and post-operative effective hemostatic coverage was nicely achieved. No clinically significant safety issues were identified, and no inhibitory antibodies were seen to the product or to the pegylation moiety. This is a dosing schedule: minor surgery, only one dose of 40 IU per kg, additional doses if needed, and major surgery as discussed. This is with another factor 9. This is with an albumin fusion product. So various surgeries have been performed. We can see that the levels of the factor 9 have been maintained throughout the post-op period, and the median factor consumption is considerably low as compared to the SHL products. Next, perioperative thromboprophylaxis. So WFS did guide against the routine use of pharmacological thromboprophylaxis for non-cardiac surgeries. For orthopedic surgery, ACCP also goes against the thromboprophylaxis. However, we should understand that the risk increases with age, and at times there will be individuals who may benefit when thromboprophylaxis is given to them, when other additional thrombotic risk factors are present in them. There are a couple of studies which are there in this regard. So 18 patients with hemophilia, 5 with hemophilia B underwent high-risk surgeries, 39% THR, and VT prophylaxis considered of compression devices. In half of them, one required one was given enoxaparin and none in the other. So no patient developed DT in the first year follow-up. And another Chinese study on 98 patients, only DVT compression stocking were given, and none of the patients developed thrombosis as such in this study as well. Real world experience from India: various centers have used factor 9 and factor 8 extended half-life products for surgical and as well as otherwise. So overall, many patients are there on prophylaxis and surgery. Across the India, surgeries, if we see KGMU 2 surgery, GMC Assam, some from Gujarat, Pune, Mumbai, Nagpur, various hospitals have shown that surgeries with glycopegylated AHLs can be undertaken, as including those in India. Lastly, I present our experience from AIIMS Delhi. Overall, over last 4 years, we have 27 patients and underwent 29 surgical procedures, mostly in hemophilia A. This is the severity division of these patients. Majority of the patient underwent major surgical procedure, 8 minor procedure, 20 of them were orthopedic. AHL was used in almost half of these patients, and almost all the patients had good hemostatic control during the perioperative period. Some complications were seen. One patient developed transient inhibitor up to 8 Bethesda unit around day 7 of surgery, which lasted around a week and then recovered. 2 patients had increased bleeding and a low factor recovery. However, no inhibitor could be demonstrated in these patients. To summarize, I want to say that surgeries can be performed safely in hemophilia patients if they are well planned and executed properly. Team approach with comprehensive hemophilia treatment team and frequent interaction between the team members is required. Pre-surgical workup is essential with factor recovery and inhibitor testing at the pre-surgical and the post-surgical period. Adequate factors should be available beforehand. EHLs surgeries are even more feasible and easier as they are able to give a sustained rise in the factor levels, and excellent control of intra-op and post-op bleeding with lower frequency and lower total doses is seen with the EHL products. This is my last slide. So crackers are like standard half-life products, bolus kind of use, and EHL are like, diyas of Diwali, which goes on to shine for a long period of time. With this, I like to end my talk and invite questions. Thank you.
Thank you, Professor Mukul, for that wonderful lecture and telling us the importance of EHL products and their importance, which has made life of hemophilics and the service providers so simple. So I request all our faculty that is present over here, those of you who wish, you can open your videos. You can use the raise hand sign and let's ask questions to Dr. Mukul, or we can have your comments, your experience sharing. Meanwhile, I'll also request the audience to put their questions in the chat box. So let's go ahead. So yes, please go ahead. Dr. Kapil, you like to ask a question?
Yeah.
Yeah.
Good morning, sir.
Good morning.
I would like to ask Doctor, how frequently do you check for inhibitors post-operatively?
So as a schedule, we check for inhibitors every second or third day, barring, when lab is closed. So usually this happens to be around in a week. Post-operatively, we are checking for inhibitors for first 2 weeks.
For first 2 weeks?
Yes.
Okay.
And thrice a week for the factor assay in the post-operative period.
So you check for factor levels 3 times in a day?
3 times in a week.
3 times in a week. Okay.
And 2 to 3 times for the inhibitors.
Inhibitors. Okay.
Okay. There is a raise hand sign where I can't read the name. So whoever you are, if you want to ask question, go ahead.
Hello, sir. I'm Dr. Rajat, sir. Actually, it's showing by name of Galaxy, sir. Happy everybody, sir.
Rajat,
Yes, yes.
Singapore. Go ahead.
Yes, sir. Sir, I would like to ask Dr. Mukul, like that, regarding the peak factor level, sir. If the factor level, pre-infusion level on the day 2 is we maintaining like 60 to 80%, right? On day 2. Okay. And if the factor level is already at 60%, like do you give the factor to the patient or not? Or like what is the like peak factor level means the maximum factor level that we have to maintain, and after 12 hours it will come out to 60%. It was initially, it would come out to 30%. So is okay with that, or we should like go higher, little higher? I hope you understand my question.
Yeah. So this is a pertinent problem. Many a times when you're what is important is that you check the nadir level in the post-op and accordingly aim to give factor to maintain the desired peak which is required. So for day 2, like you asked, the peak, the desired level is around 70 to 80%. If you are already having a 60 to 70% of the factor, assessed nadir on day 2, which is what is desired. So probably you will not require to give a dose on that day. I'll go on to check the factor on the next day.
Okay. Thank you, sir. Thank you.
Shall I ask my question, sir?
Yeah, Dr. Radhika, please.
Yeah. Thank you, Dr. Mukul, for your presentation. My question is like, what is your institutional protocol of perioperative thromboprophylaxis? How do you practice in AIMS? Do you consider surgeries?
So for our orthopedic patients, majorly, so they are giving only compression stockings and no anticoagulation is advised from our side. which is in accordance with the most of the World Federation of Hemophilia guidelines as well as ECCP guidelines. So no, at least pharmacological prophylaxis we are not giving at present to our patients.
I had a patient, hemophilia patient, who underwent a cardiac bypass surgery. So the surgery went on very uneventful. So what about the prophylaxis now post surgery? The cardiologist want to put him on prophylaxis because it's mandated. It's a cardiac surgery, but I'm skeptical.
Yes.
So how do I handle this particular case?
So you should just remember that's a very pertinent question, I should say. So we should remember that for a normal individual, factor assay is more than around the 40 to 50%. If you're maintaining the factor level more than 60-70%, essentially that patient is unlikely to bleed at that level, unless of course he develops inhibitors. So for such a patient with the high thrombotic risk, probably thromboprophylaxis will be required.
The patient is on the verge of getting discharged.
Yes.
He got discharged. Prophylaxis to be put or not? Or
Yes.
on prophylaxis?
So thromboprophylaxis will be required. At least in the immediate post-operative period, he will require thromboprophylaxis. Subsequently, when you're putting the patient on prophylaxis with respect to hemophilia, those are the time when it might be a bit trickier.
Yeah. Not sure. Not prophylaxis for him, but tough call that time.
Thank you, Dr. Radhika. I request everybody to mute themselves. There's a lot of background sound. Dr. Akanksha, your question.
Hi, sir. Very nice talk and interesting data. So I just wanted to ask, was there any risk of thrombosis in any of these patients where you had used the EHLs in your study? And the second question was that, is there a low and high dose protocol or regime with respect to EHL?
Both have pretty good question, Akanksha. So with respect to the low and high dose regime, so as far as I am aware, that has been prescribed with respect to SHLs only at present. And the data from the surgical studies, which are from various, for various, Novo Nordisk or the Baxter product, which has come up, they've used a standard prophylaxis dose, which is fixed as per the study. So beyond that, real world data is yet to come with respect to the lower doses prophylaxis. One thing we can see that for most of these products, we end up using far less amount of factors as compared to the SHL product. So that is something, by and large, as I showed in one of the data, especially with factor 9, so the patient was requiring almost like 1/5 of the factor consumption as compared to the SHL products. So overall, the factor consumption is lower with EHLs. With respect to thromboprophylaxis, the data, as has been reported in studies, is negative. Our experience has also been negative, and the two studies which I showed with respect to thromboprophylaxis, they were also, more or less negative studies with respect to any of the prophylactic measures that they are doing. So no incidence of thrombosis was seen in any of these two studies as well.
Thank you.
Thank you, Dr. Akanksha. Dr. Shruti and then Dr. Rajat.
Good morning, sir. I actually didn't have a question. It's kind of a new thing for me. We don't somehow, manage hemophilias at our center. So just wanted to thank Dr. Mukul for giving this talk and, just making us aware of all the things. Thank you, Dr. Mukul. Thank
you. Okay, thanks. Dr. Rajat, your question.
Hello, sir. Thank you for giving me an opportunity to ask another question, sir. Sir, I would like to ask risk of inhibitor development with recombinant factors. Initially, as far as I know, that it was told that recombinant factors are more predisposed to form inhibitor. But later it has been shown that there is no difference between plasma derived and recombinant factor. Can you throw some light on it, and also what happened in the SIPL trial according to it?
Dr. Rajat, there was this SIPET trial study which showed that perhaps the risk of inhibitor development in patient on prophylaxis with plasma derived factors was lower, but that studies have been debated a lot in the hemophilia circles. And the current word is that there is not significant difference in the either recombinant or plasma derived factor with respect to inhibitor formation. Dr. Chandrakala ma'am can correct me if she can give input on this.
Chandrakala, do you want to add something?
Yeah. Thank you, sir. Yes, as Dr. Mukul told, this CPET study has shown that plasma derived with VWF rich, not all plasma derived is same. Plasma derived with VWF has shown a decreased chance of inhibitors. That is a low risk inhibitors. So what we are worried is like high risk inhibitors. The low risk inhibitors are decreased only within 50 exposure days. So they are very clear cut inclusion criteria in this trial. If you're starting a pediatric patient, so the low risk inhibitors can be reduced by almost 1.53 times when you use the plasma derived factors. So this has not been accepted all over the world because a lot of inclusion criteria. The inhibitor titer which was used is 0.3. So all the WFH guidelines also has mentioned that it may decrease the chance of inhibitors, but it's not a rules that you have to start plasma derived factors in patients. So it is only in European study and in a lot of Indian patients has been given. So if you're given a chance that because in our country management of inhibitors is very difficult, you can start pediatric patient prophylaxis with VWF rich factors up to about 6 months, and then you can change out to inhibitors. So if I get one more chance regarding EHL low dose, somebody asked a question. Low dose has been studied EHL prophylaxis, 10 IU per kg once a week, factor 9 EHL factor has been studied, and it has shown a factor 8 trough levels of 8%. It has been shown that very good trough levels with 10 IU per kg. It has been studied with factor 9, but there is no data of factor 8. And cardiac surgery, we have actually patients who has got bypass surgeries. And usually our cardiologists always they ask for the drug-eluting stent, which requires double antiplatelet drugs. But the WFH recommendation mentions that you should put a bare metal stent. If you can talk to your cardiologist, put a bare metal stent where only antiplatelet drug can be given only for initial 3 months, and then you can change to. There is no need for continuing the antiplatelet drugs. But as per the WFH guidelines, if putting the patient on double antiplatelet drugs, you should maintain the factor 8 level trough levels of at least 15%. That becomes a very huge dose. For us, it is very difficult to continue. We give what is like low dose. We give, but if you have a EHL, we give about every second day or third day we give initially. And we still had a patient who is on actually at such a high dose. We had a paraspinal hematoma who had undergone cardiac bypass surgery. On low dose prophylaxis, he had a paraspinal hematoma. So we had to take off his aspirin and then clopidogrel. So it is just actually we have to be careful when we're giving antiplatelet drugs to hemophilia patients. Thank you, sir.
Thank you, Dr. Chandrakala.
With respect to that low dose portion, so that in that study it was compared between 10 IU and 40 IU. Both had nearly similar rates of protection which was there. So 10 was giving around 8% trough level and 40 was giving around 15 or 18%.
23% trough level was
around 23% trough level.
And almost 5 days they had more than 40% trough level. So it was very good trough levels with 40. 10 is also not very bad. It's really good for our scenario.
That was for prophylaxis. Correct me, ma'am. I think for the surgical part, there are no high or low income kind of studies which are there, which were described for SHL.
Oh, no. We cannot take a chance for surgery. We have to give a standard recommendation for the surgeries. Yeah, that is not. Yeah.
Thank you. Dr. Akshaya, your question.
Good afternoon, everyone, and happy Diwali. Thank you, sir, for the wonderful lecture. Sir, I would like to ask, how do you manage pseudotumors with inhibitors?
So, Dr. Akshaya, pseudotumors are problematic. With inhibitor, they are even more problematic. So, I had, stick to the talk in this regard and hidden these slides on inhibitor surgery. So, patient with inhibitor, they have also undergone surgeries. The hemostatic control is not excellent or good in all of them. So moderate risk of bleeding has been there with many of the surgeries. So the products are standard ones only, factor 7A or APCC's kind of product like EBA. These are the two commonly used products for these surgeries. The support and the dosing schedule varies. Patients on emicizumab have also been taken up for surgery. That data is also available. For those patients, additional doses of factor 7A is required in the perioperative period. The standard schedules are there. So the surgical team, the orthopedic or the surgical team decides about the surgical management. Our role at that time is to maintain, guide them through the adequate factor doses and proper bleeding control during the perioperative period. I hope that.
Thank you, sir.
Question.
Yes, thank you, sir.
Thank you. Dr. Arihant?
So,
Hi, Arun.
yeah, Dr. Mukul, so am I audible clearly first of all?
Yes.
Yeah. So what I wanted to ask was 2 or 3 practical questions. One, at least in your center, in the post-op period, where do you prefer to keep these patients? Whether you would keep them in an orthopedic ward or under the hematology care? At least we do under our care. But sometimes there is a difference in opinion on the day of discharge. Like we would tend to be more comfortable discharging early, but our surgeons would not. So just wanted to have.
Arihant, as a departmental policy, we rarely admit the patient for surgery under us. The patients are admitted under the primary surgical unit. So be it surgery, be it ophthalm, be it orthopedic commonly, or be it trauma. So patients are admitted with them. We see the patient on a daily or twice a day basis and guide about the prophylaxis. It is the surgical resident as well as my resident job to ensure that the factor level and inhibitor tests are done on a periodic basis. My experience with respect to discharge has been quite opposite. The surgical team are comfortable discharging the patient on the 3rd or the 4th day of the surgery. We usually request them to keep the patient for a longer time in the hospital, as I am wary about inhibitor development, especially around 2nd week. But with a good daycare support, we ask the patient to come to daycare for factor infusions, at least in the first 2 weeks, so that we are able to check the factor level as required. In addition, we also give the patient for home infusion if required. So our protocol is slightly different from what we are following in this regard.
Yeah, thanks. And one more question, if I'm permitted. So this is like once those 14 days post-op are over, and most of our patients would be on a on-demand kind of a protocol, and the standard patient would be, say, a knee replacement surgery of a severe hemophilia without inhibitor. So after that 14 days, do you give them a short-term prophylaxis, say for 4 to 6 weeks, or because that's probably the time where the physiotherapy is kind of more active, or after 14 days you are comfortable on an on-demand kind of a schedule?
That is a very important practical question which you have asked. So advice is to put the patients on prophylaxis. This happens at least at my center in almost 60, 70 or maybe 80% of the patients. Some of the patients are not there on prophylaxis, that I agree. But when I'm asking, we get the factors from the Hemophilia Federation. So when I'm asking for the factors from the HFI, I keep this thing in mind and keep this demand in mind while requesting for the factors. So at least for the 1 month prophylaxis, I'm requesting for the factors.
Oh, thank you.
Thank you, Arihant. Dr. Amrita.
Hi, thank you, sir. Actually, my question is not exactly about a little, away from the topic, but I would like to appreciate Dr. Mukul's lecture. He did it very well. Actually, Dr. Mukul, my question is like, have you ever come across inhibitors in a case of factor 10 deficiency? Because we recently, in fact, day before yesterday, there was a case from a different hospital where he was diagnosed as factor 10 deficiency at a younger age, and now he developed pseudo tumor and was posted for surgery. And they wanted to find out like about the inhibitors screen. So truly speaking, I have never come across like such kind of inhibitor screen or how to see this. And we did the factor 10 levels, which was again moderately reduced around 3.1. So I would like to know if what's your experience and what's your comment about such a case?
Pass. Sorry. No experience. Pass.
Ask Chandrakala if she wants to answer.
No, we have not seen any factor 10 inhibitors. We have seen VW with inhibitors, factor 13 with inhibitors. Inhibitors can happen any of the deficiencies.
Yes,
we need
ma'am.
to test before actually, but we have not seen anything actually like that.
Because they were very, very, anxious about it. Like, we are going to perform a surgery and, the levels are low, so we don't know. And I also tell them like, I have also not seen development of inhibitors, even though it's like not impossible. But truly speaking, I also have to find out how to deal with such a situation. Thank you.
Long time
Anyway.
back, seen a patient with factor 7 with inhibitors, barring that, none with the rare factors inhibitors.
Right.
They're not on any kind of prophylaxis, are receiving factors, FFP for the practical purpose. Most of them are receiving only FFPs for most of the part.
Yeah, I think that's what they are also planning to do. Thank you.
And for factor 10, maybe you can consider for the PCC product, which is available in the
Yeah, we have done surgery
Right.
in factor 10 actually. TKR we have done with using PCC actually. APCC actually. We have done with
APCC.
APCC. Yeah.
Okay.
We have currently a term pregnancy patient who is planned for delivery somewhere.
Yeah.
So we are arranging for the that octaplex injections or.
Right.
Kapil, you want
Thank
to
you.
Yes, yes. I wanted to ask another question. In response to a question from other participant, Dr. Mukul, you said that if factor level is about 60% on day 2 of surgery, you won't go for factor infusion and you will check for factor level the next day only. So keeping in mind the half-life of extended factor 8, 16 to 18 hours, the level by the next day will be about 20-30%. So don't you think we should give small amount of factor infusion on day 2 also?
So if you're aiming for 80% correction, maybe you can give around 80% of the factor. If you are aiming for, maybe you can give a 20% correction on day 2. So the range is around 60 to 80%. So that will be left to our discretion. You should remember that these are the Nader level which are to be checked. So we expect on day 3 the level will be half of that.
Yeah.
On day 3 my dose will be push the factor to around 80%.
So Nadir, at what Nadir you would like to keep on day 2, 3?
So Nadir, in my practice, I usually keep it around 80.
So that's what I'm saying.
Yeah.
So if level
Usually around 80.
Yes, level day 2 is 60%, then I think we should give some amount of
maybe
factor
around 20% correction you can.
Because otherwise the factor level by the day 3 will be very much less.
But that correction will not be like the complete day 2 dose.
Yeah, definitely. Yes.
Thank you. Dr. Radhika, you have another question? You are muted, Dr. Radhika.
Yes, sir. My question is similar to Dr. Arihan's question. Post-major surgery or post-traumatic bleed, we manage patients with factor 8 till the bleeding stops. So once the bleeding stops and the patient is on discharge, is ready for discharge, do we stop the treatment post-surgery? Yeah, you are very clear that we need to put him on prophylaxis for 1 month. Post-major trauma, treated the patient. Now the active bleeding has stopped. Patient is being discharged. Do we continue a factor prophylaxis till the wound heals? Does factor help in wound healing also? Or do we support only till the bleeding stops? And the wound healing is a different part.
The WFH guideline, they divide into major and minor surgeries. So trauma surgeries, usually are kept within the scope of major surgeries. So at least 14 days of prophylaxis is required for these patients, irrespective when the bleeding stops. So ideally, bleeding should stop by day 2 or the standard hemostasis, which is expected in with respect to the trauma. So I won't say that all the patient of trauma will have no bleeding on day 2 or day 3. That will depend on the extent of trauma. But if you ask me with respect to the hemophilia per se, the patient should have adequate level by day 2 of surgery, and that should be maintained as per the guideline by at least up for till day 14.
No, bleeding has stopped.
Depending on the need of physiotherapy, you have to give extended prophylaxis if required.
The wound is still like there's gaping of the wound. The wound is on the verge of healing. It's going to take some more time. So, do we continue factors till the wound heals? Does it?
Prophylaxis, probably prophylaxis.
Yeah, sure. Thank you.
Thank you. Dr. Rajat. Dr. Rajat, you have a question? Dr. Amrita, you have a question? So we'll take some questions from the audience now. Dr. Krishna Ratnam Kanan wants to know if pre-op inhibitors are negative, is it necessary to check the inhibitors post-op?
Yes, this is very important because surgery being a major risk factor and inflammatory milieu around, development of inhibitors has been reported in the perioperative and the post-operative period as well. So usually around a day 4 to 5 to around 2 weeks of post-op period, post-surgery, patients have known to develop inhibitors. So screening for inhibitors is required in these patients. We usually do it at least twice a week in the post-op period. If you're checking for factor SA per se, the inadequate recovery will guide you that the patient is developing some kind of inhibitory antibodies.
Thank you. Dr. Ali Mahmoode wants to know, how do you see the accuracy of mixing studies for inhibitor screening in a setup where inhibitor antibody assay is not available?
That's slightly tricky, sir, for me. I'll still guide you that you should refer the patient to a standardized lab for proper inhibitor assay. Difficult to try and gauge this thing, especially for a surgical patient, where almost all accurate results are required, especially if you're planning for any elective surgeries. Refer the patient to a center where all these facilities are available.
Thank you. The other question he wants to know is, in low-income countries, what is your usual advice to the surgeons?
Sir, couldn't get it, sorry.
In the low-income countries, what advice do you give to the surgeons for operating hemophilics?
No special advice is, the surgeon should be experienced and ready to handle patient with hemophilia, understanding that the risk of bleeding is usual. We are providing adequate prophylaxis to the patient, probably more than adequate factor level to the patient, and that fear of hemophilia should go away from the mind while performing the surgery. That is very important.
Right. Dr. Raghavendra wants to know about the reconstitution and administration and monitoring details of EHL. Are there any specific steps?
No specific steps per se. The reconstitution is similar. You reconstitute with the diluent provided and infuse it over 4 to 5 minutes slowly. Nothing very different from the SHL products.
Right. There's a technical question which you may or may not answer. Wants to know the technique of inhibitor assay.
Sir, only the name Nijman technique, Nijman Bethesda technique.
Right, fair enough. So that was the last question from the audience. Is the faculty over here interested in asking any other question to Dr. Mukul? If none, and as for some unknown reason, our first speaker has not been able to join us. So I think on my behalf, I thank everybody, including Mukul, Chandrakala, and all the participants in the discussion and the audience. And I hand over the platform to our sponsors now. So yes, Dr. Inge is there. Yeah.
Thank you so much, sir. It's been a wonderful session, I believe, and I think everyone has been too much into understanding more about hemophilia. That's great to know as well. Firstly, I thank you, sir, because for driving this again and also bringing hemophilia and its awareness to the next level. Thank you, Dr. Chandrakala, also for gracing the occasion as a chief guest and also giving your expert opinions. Thanks a lot, Dr. Mukul, for the wonderful lecture. It's amazing to hear you as always, and also giving your inputs and also addressing the queries as and when it was coming through. And to all the discussants and the faculty experts who are there in this forum, we have a multitude of eminent faculties. And thank you for your interactions, questions, and comments. And that has uplifted the discussion to the next level. To our dear audience, thank you for your time. It's a Sunday afternoon, festive season. You have spared your time for this important meeting as well. Thank you so much. And I'm sure you look forward to many more such webinars as well. And on behalf of Novo Nordisk, just like to say that just like how we are committed to bringing innovative medications, not just from the Europe setup, but also to India, as we're speaking on glycopegylated EHL factor 8 or 9, or even in other rare bleeding disorders, our endeavor is also to enhance the educational aspect of it in such forums, be it medical education activities at a national level. So we thank you all for your patient listening. We thank all the faculty experts once again for their time. And with this, I also wish everyone a happy Diwali and also a great weekend ahead. Thank you all. And I would probably conclude from my end here as well.
Thank you, Dr. Inge. Sincerely wish very, very happy Diwali to everybody and the family, friends. And with that, we close this particular episode and we meet next Saturday. Thank you very much.
Thank you, everyone. Happy Diwali.
Thank you. Thank you, everyone. Happy Diwali to all.
Happy Diwali.